We talked about hypokalemia as being a major factor in maintaining a metabolic alkalosis. We went over the several mechanisms whereby that may occur. Let's also review how a primary increase in mineralocorticoid or ENaC activity may be playing a role. Again, this should be recognizable or familiar concepts that we need not belabor. So if I have mineralocorticoid excess, then I am more apt to generate that lumen negative potential difference in the collecting duct, favoring both K loss as well as proton secretion, right? So proton secretion is also um, uh, facilitated or stimulated by the mineralocorticoid receptor. When aldosterone is bound to the mineralocorticoid receptor, it stimulates proton secretion. Once again, acid excretion is equivalent to gain of base. So in patients with primary hyperaldosteronism, we will at times see serum bicarbonates that are on the higher end of normal. Usually you don't have overt metabolic alkalosis, unless the K depletion is profound, these patients will tend to have simply a mild increase in serum bicarbonate. Now, it wouldn't just be the classic primary hyperaldo patient, but other syndromes in which functionally there is an increase in mineralocorticoid activity through things like glucocorticoid remediable hyperaldosteronism. You'll recall the mechanism in this, or the pathogenesis involves ACTH-mediated stimulation of aldosterone synthase. Apparent mineralocorticoid excess is a inhibition of the normal deactivation of cortisol at the tissue level, such that cortisol is able to bind the mineralocorticoid receptor. So it's a defect in this dehydrogenase enzyme. And then Cushing syndrome is self-evident based on the prior discussion. A primary increase in ENaC activity through Little syndrome would also be predisposed to this metabolic alkalosis. Okay. The high distal sodium delivery from that volume expansion arising from mineralocorticoid activity, stimulating sodium reabsorption via ENaC would further enhance the generation of lumen negative potential difference, right? So, and then proton secretion follows, as does many times K loss. Okay. Now, when we're evaluating metabolic alkalosis, okay, let me pause and let you catch up. You'll need to tune in here because this is a frequently tested concept. It's also clinically relevant. Many times we're using urine chloride to help us distinguish from the several factors that may cause a metabolic alkalosis. Okay, let's go through why we're using urine chloride instead of urine sodiums. Well, urine sodium can be confounded when there, as a measure of effective circulating volume, when there is bicarbonaturia. So if I have metabolic alkalosis, right, a situation in which HCO3 is high, my filtered load of bicarbonate is increased. If I may have scenarios in which, again, my bicarbonate delivery to the collecting duct is fairly robust. That is a lumen negative potential difference, or that contributes to the lumen negative potential difference, and therefore is favoring the loss of K as well as sodium in the urine. So reabsorption of sodium via ENaC would be potentially uh, limited by the fact that there is an obligatory loss of cation driven by the anions that are delivered to the distal nephron, right? And in this case, urine sodium, even though a patient may be um, volume depleted, urine sodium may be an imperfect measure of circulating volume in that scenario. And so checking a urine chloride urine chloride would be expected to be low in cases in which there was low effective circulating volume, and even despite the presence of bicarbonaturia, urine chloride will be conserved. Okay, so urine chloride is perhaps your better surrogate for circulating volume when you have bicarbonaturia. Okay. Yep.
Is this true if you have other conjugate bases too, like you have a septic patient who gets antibiotics, something?
Yeah, so the question is, would urine chloride potentially be more reliable measure of circulating volume in other scenarios in which I have other anions in the urine? The answer to that is theoretically yes, right? And Naveen highlighted maybe the use of piperacillin, a negatively charged antibiotic that is cleared through renal clearance, may confound the use of a urine sodium as a measure of circulating volume in other scenarios. So theoretically, yes. Okay. I've said, however, we give lots of piperacillin, and I have not seen much K wasting in piperacillin induced, well, from piperacillin. I see it in questions. I see it, but I don't see it in clinical practice. Okay, so I would not suspect that the use of Zosyn is going to confound our urine sodium. Okay, theoretically it could, or the presence of hippurate in the urine or keto acids in the urine. Any anion could theoretically confound the use of a serum of urine sodium to interrogate circulating volume. All right, now. Um, in scenarios in which I have, for instance, non-renal loss of salt, right? So the classic is upper GI loss, right? Upper GI loss, such as NG suction or profound nausea and vomiting. Then again, urine chloride will tell me that this patient has low effective circulating volume, and even if urine sodium is relatively or is not low. Okay. So that's one classic hypothetical in which urine chloride would be low despite the presence of bicarbonaturia in some patients. Okay. Let me state the point though, that if you are profoundly volume depleted, even from NG suction, it's quite possible that yes, you will filter more bicarbonate because GFR may be relatively preserved, and you have a serum bicarbonate of 30 plus, right? But if I have very low effective circulating volume, it's possible that all of this bicarbonate is reabsorbed in more proximal segments, such that my bicarbonate delivery to the distal nephron is low. You'll see in these patients, right? I encourage you to take a look at the UA of the patient who presents with vomiting and alkalosis. Many times the urine pH in those scenarios will be 6.5. That tells you there's not much bicarbonate in the urine. And then in that case, urine sodium would be still a reasonable surrogate of circulating volume. So this is not always at play. It's sometimes at play. Okay. Now, in contraction alkalosis or diuretic induced alkalosis, I may check my urine chloride. And of course, my urine chloride, if I'm giving a diuretic recently, will not be low. Okay. So loop diuretic induced metabolic alkalosis, thiazide induced metabolic alkalosis, the Barters and Gittlemans, which are the analogs of loop and thiazide diuretic induced metabolic alkalosis, would have a urine chloride that's not low. Okay, so classic question that you may be posed is a thin female that has all the appearance of somebody who might have anorexia, who comes in with alkalosis, is either abusing diuretics or vomiting through bulimia. You'll use a urine chloride to interrogate which of those possibilities exists. Or, they may have an undiagnosed thiazide or Gittleman's syndrome, for instance. Okay, so urine chloride is often used to interrogate metabolic alkalosis. Tells you whether they're salt wasting or not. And so I've gone through some of these differentials. Let's go through the chart now. Okay, so I have metabolic alkalosis with low urinary chloride. In that case, there's really, again, upper GI loss is going to be a big one. And then these very rare lower GI losses that can be chloride rich. So for some reason, certain villus adenomas um can cause a secretory diarrhea that is chloride rich, resulting in metabolic alkalosis. There's a defect in an intestinal chloride transporter that can do the same. Cystic fibrosis is a scenario in which you have altered salt transport in various epithelia, right? The most significant of which is in the respiratory tree, and that results in bronchiectasis and impaired mucus clearance. But these patients also have actually excess sodium chloride loss in skin, okay, as a result of some of these transport of the chloride transport defect, right? So if they are losing chloride through skin losses, that theoretically also can cause a hypovolemic picture and a metabolic alkalosis. Okay. Now, thiazide and loop diuretic should have a urine chloride that is high. However, if you checked labs several hours after thiazide or loop diuretic, then my urine chloride can of course, be low in that scenario, right? They're volume depleted. The effect of the thiazide or loop diuretic is no longer inhibiting, is waned and is no longer inhibiting thick ascending limb or DCT transport. And so my urine chloride would not be high in distant thiazide or loop diuretic use. Now, urine chloride will be high when I have patients that have the hyperaldo syndromes, right? This is just more hyperaldo syndromes, which we've talked about in our hypokalemia esqueletas. Again, renal artery stenosis, angiotensin-mediated hyperaldosteronism. Again, these are all going to be syndromes of essentially excess mineralocorticoid activity or ENaC, dysregulated ENaC activity. Yeah, I'm actually missing littles here. So littles should be added here as well. Am I missing it? Yeah, I am missing it. Okay, so variable blood pressures may be present, often low blood pressures when the loop and thiazide diuretic are on board. If I give sufficient alkali, that I filter that alkali in the urine, I get a mild metabolic alkalosis plus, sodium wastage, potassium wastage in the urine. Remember that bicarbonate is drawing out sodium and potassium, but you're also giving this alkali with salt. And so in general, their sodium and potassium excretion rates would be high because these are generally going to be volume expanded patients because the alkali comes with a cation, often sodium bicarbonate, sodium acetate, sodium lactate when you're giving lactated ringers. So in these scenarios, if you give enough bicarbonate, you can have a mild elevation in bicarbonate. Urine chlorides will be, obviously high if they're getting volume expanded with salt-containing alkali therapies, right? This is a patient who has hypercapnia and develops the metabolic compensation to hypercapnia, i.e., metabolic alkalosis. These patients, unless they're concomitantly hypovolemic, would have urine chlorides that are not low. I mentioned Pendred syndrome the other day. Go over again this uh, transport protein here in the beta intercalated cell. If I have a mutation of this gene, my capacity for bicarbonate excretion will be somewhat blunted. However, in the intact individual, you will not manifest metabolic alkalosis because you're able to excrete bicarbonate even despite this small defect in bicarbonate handling. However, if you cause another predispose, if you institute or you're assailed by another factor that tends to cause an alkalosis, such as a thiazide therapy, a loop diuretic therapy, K depletion, or you start to vomit, or you start to generate more bicarbonate, their capacity of bicarbonate elimination may be exceeded, and then they develop a metabolic alkalosis with that second hit. Okay. Turns out that simply putting individuals on very low K diets is also a cause of metabolic alkalosis because of these same factors which we discussed previously. Multiple pathophysiologic factors contribute to the metabolic alkalosis, and this is even described again in the Selden years when he took quote unquote willing medical students and he put them on low or no K diet for several days. They will start to exhibit metabolic alkalosis. So K depletion itself is a profound factor for in the case of metabolic alkalosis. Management in general, all you need to do is restore blood volume when you have volume contraction mediated metabolic alkalosis. And your kidney, remember, has this immense capacity to dump bicarbonate, right? Because it filters thousands, as we said yesterday, thousands of millimoles of bicarbonate. If you subsequently turn off, right? You're filtering tremendous amounts of bicarbonate. The problem is it's being reabsorbed in the proximal tubule. But if I expand blood volume, then this reabsorption is diminished, and then I dump lots, let's call it gobs of bicarbonate in the urine, right? And I can correct the alkalosis itself. So even if you were to expand the blood volume with, for instance, lactated ringers has bicarbonate equivalents in it, you will correct the metabolic alkalosis, even if you choose to do that. Now, the elegant solution is to give a chloride-rich IV fluid that is sodium chloride. That would be a more rapid, modestly so, more rapid correction of metabolic alkalosis because giving large amounts of chloride has its own direct effects on the kidney's capacity to dump bicarbonate. Okay, so again, give sodium chloride ideally, but volume expansion is really key, and correct any K deficits. So K chloride is going to be your treatment, part of your treatment algorithm as well. Giving K chloride is very similar to giving hydrochloric acid in a patient who has K depletion. Why? When I give K chloride to a patient with metabolic alkalosis, remember, 98% of K goes into the cells, right? Most of chloride stays outside of the cell, okay? If K is going into the cell and chloride is staying outside of the cell, remember, I'm having cations move outside of the cell as well. So it's as if you're giving hydrochloric acid to your patient when you give K chloride. In fact, if you have an anephric rat who you induce alkalosis from, or a dog, and you give K chloride, you can detect proton concentrations go up quite significantly if you give large amounts of it. Okay? Proton concentrations in the ECF. All right, so K chloride is, again, an important part of the treatment of patients who have metabolic alkalosis. So as long as a patient is not hyperkalemic, I will give them K chloride. All right, for diuretic-induced metabolic alkalosis, that is still, and you still have hypervolemia, that's when you're starting your medications like acetazolamide to try and enhance bicarbonaturia. Again, I encourage you to try checking the urine pH in some of these patients that you are diuresing aggressively, who are still volume expanded. You'll often find that their urine pH is not alkaline, right? Because again, all of that filtered bicarbonate in that low ECV state is being reabsorbed proximally. I often give the acetazolamide and check a UA later just to sort of for teaching rounds, and I show you, look, urine pH, even though the bicarbonate was 40 or 35 when we started, the patient was filtering bicarbonate but not excreting bicarbonate. We gave acetazolamide, and now you can see the urine pH is 7.5, right? Aggressive K deficiency is once again key. I introduced potassium-sparing diuretics early on in the treatment of these volume-expanded patients. Essentially, once I see that the patient is dumping 4 liters per day of urine, I still have 5 kilos to go, I will preemptively put somebody on a mineralocorticoid antagonist. When you get alkalosis and you're still hypervolemic and you're wanting to squeeze them harder, it's really pretty hard to reverse the alkalosis at that point. So prevention, in my view, is key. And the early addition of that mineralocorticoid antagonist reduces proton secretion, reduces K wastage, and so you mitigate the metabolic alkalosis that you would otherwise see. So prevention is key. So as soon as a patient is dumping 4 liters of urine, as long as they're not hyperkalemic and acidotic, I will put them on spironolactone. Rarely, you can actually give various forms of acid. Hydrochloric acid is the most intuitive, but the administration of arginine and lysine chloride are also acid loads, right? We talked about at the start of our conversation the metabolism of basic amino acids, basic referring to at a neutral pH, right? At a neutral pH, they carry a proton. When I metabolize lysine or arginine chloride, I have to liberate that proton. The result is an acid load. The metabolism of lysine or arginine chloride is an acid load, and those are prescribable, especially arginine chloride. It's prescribable. You often have to, it's not on formulary, you have to get it, but you can prescribe it. Okay, and then we have published a novel use of sodium thias, or we're trying to publish a sodium thiosulfate as another treatment, but that is off-label and not in the published literature yet. Okay, respiratory acid-base disturbances. I won't spend a long time with these, except to sort of highlight a couple of other concepts that we've previously touched upon. Remember, you see this 0.03, that number should be familiar to you. That is a way to convert a PCO2 into essentially a concentration. When we were looking at Henderson-Hasselbalch's equation, you'll recall that it was in this case, the denominator of this term of Henderson-Hasselbalch, right? So I'm giving you that back. Um, um, there's also some information here that may be relevant when you're thinking about patients who are on ECMO. We sometimes are talking about the generation of CO2 in terms of volumes of CO2 gas generated during respiration, and you can back calculate how many millimoles that would account for through this equivalency that I'm providing you. And then I've said that, again, CO2 generation rates are much higher than the non-volatile acid that you excrete, but the lungs are quite adept at eliminating CO2 unless you have problems with ventilation, COPD, or OSA, for instance. Okay. In general, when I have a problem with hypercapnia, it is going to be in essentially all cases a problem with blowing off the CO2, not by generating excess amounts of CO2, because again, the lungs have this immense capacity to excrete CO2. Okay, that's what this paragraph refers to. Look for problems with ventilation. You don't have to worry so much about CO2 generation rates when you see hypercapnic patients. Um, how much should I spend on this pulmonary? Let's just be brief, okay? So what the PaO2 is determined by my ventilation, okay, and not so much by my generation of CO2. So generation of CO2 is a factor, but is going to be relatively small, okay? This is simply a conversion factor that allows you to relate CO2 generation rate and alveolar ventilation. So in the denominator of this equation is respiratory rate times my alveolar ventilation. What is alveolar ventilation? It's going to be, if I have a patient on the ventilator, my tidal volume subtracting any dead space. What is dead space conceptually, right? It's that air that's in the trachea or in the main brainstem or the main bronchi, or in alveolar units, which are filled with pus, right, or water and have incomplete gas exchange. So all of that is dead space, right? So tidal volume minus dead space is simply alveolar ventilation. This relates again, in most cases, I have problems who are breathing too slowly or not large enough breaths or their dead space is large. Okay, so that's the differential of a primary hypercapnic respiratory failure or respiratory insufficiency. Here are your compensatory formulas, right? When I have respiratory acidosis or alkalosis, there's an acute and chronic compensation to these. I'll focus on the renal part of this equation. Notice that I need not have any time in order to manifest the acute compensation, right? If I cause a respiratory acidosis, I will immediately tend to have an increase in serum bicarbonate. That does not require a functional kidney, right? This happens immediately. What is happening that can raise my serum bicarbonate in that acute setting? When I have CO2 that is increased, that CO2 can form in the setting of, right, can be hydrated. I can add H2O. Looks like I have some dead spots on this side of my computer, right? And I can form basically CO2, HCO3, excuse me, and a proton, right? So what I can do with this is hemoglobin has the capacity to buffer some of these protons. And I can use the red cell to buffer protons and still increase my serum bicarbonate. There is also an effect of bicarbonate excretion and chloride absorption that happens on the interface of these red cells. So again, this augmentation of bicarbonate is the result of the CO2 and its conversion to bicarbonate, as well as, and the proton, meanwhile, vanishes, is buffered by hemoglobin. And again, there's other ways. I have carbonic anhydrase inside the red cell. Sorry, carbonic anhydrase inside the red cell, and I can create bicarbonate and dump that into the ECF as well. Again, I do not need renal function to manifest the acute compensation to either respiratory alkalosis or respiratory acidosis. Okay, I do need renal function to manifest these chronic compensatory responses, right? The kidney in a respiratory acidosis starts to dump more protons in the urine and generate this compensatory metabolic alkalosis. So the response to respiratory alkalosis is to dump more protons and increase bicarbonate generation by the kidney. When you go to a high altitude and you have respiratory alkalosis, your kidney essentially holds on to acid. Net acid excretion goes down. I also am excreting bicarbonate. I dump bicarbonate in the urine. In fact, for those first 2 days after you go to a higher elevation, you'll see a urine pH that goes up for those first 2 days, and then you're compensated. The urine pH comes back down to your normal if you're eating a typical Western diet, 5.5 or 6. Okay. So those do require renal function.